are not transplant candidates. And in these patients, we try to do mostly like palliative therapy. Some patients with, say, skin disease only, they can benefit from skin-directed therapy, like, for example, radiation, Interestingly, although it's extremely aggressive disease and most of patients die within 2 years if they don't undergo stem cell transplant, and median survival is around a year. So these patients, obviously, we try to balance, toxicity and efficacy. So we use very mild approaches, mild chemotherapy, sometimes even oral chemotherapy. I had even patients who did well on steroids only. We couldn't do chemo because it was patients who had cytopenias because of MDS in bone marrow, so you couldn't use chemotherapy regimen if I would like to do it, because when patient would develop severe protracted cytopenia. So in these patients who are elderly, we really don't have anything what could keep them going without either significant toxicity or without progression of disease,
And when you came across SL401 data, how do you think about it? How do you think about it?
It's obviously a significant change. It's I would say game changer here, because especially patients who say are not in good shape. For these patients, using chemotherapy sometimes put them in hospital, where quality of life was poor through chemo. And even if they responded to chemotherapy, and interestingly, this disease can be sensitive to chemotherapy or even steroids initially. Subsequently, most of patients relapse and develop chemotherapy refractory disease. So in these patients, we really didn't have anything to, as I mentioned, keep their quality of life reasonable without too much toxicity. So SL401 data look definitely really amazing, because until that we didn't have anything what could somehow what you could use to achieve such high responses with relatively minimal toxicity. So obviously, jury is still out. We don't know how long these responses will last. We obviously don't know whether that agent can cure anyone, and we also don't know what will. We don't have still data on these patients who would. At least to my knowledge, I don't know information how many patients now in these phase 2 studies remain in remission and continue on treatment. So once we have obviously final publication from that phase 2, we will be able to somehow assess efficacy of that agent better, and also there will be a longer follow-up, which we need to see whether this could be used for elderly patient as a frontline therapy as well as maintenance therapy.
Can I just ask, would you, two questions. Obviously, we're not familiar with the ramifications of capillary leak. Can you just explain, because it sounded like you thought the profile from a safety perspective was quite positive. Can you just explain to us what that is and how big a deal it is? And then secondly, in theory, would you use the drug in maintenance without a clinical trial showing its benefits?
So as far as capillary leak, fortunately, before this agent was introduced, most of oncologists have experience with similar agent called ONTAC. And ONTAC was approved almost 20 years ago.